The world's best physios don't just treat, they coach. Here at the Physio Coach podcast, we invite the best physios, coaches, and health experts to inspire you on your journey to becoming a physio coach. This podcast is sponsored by Better, provider of in-person physio and personal training services in central London. We help people feel better, then live better. We believe that better never ends. This podcast exists to inspire your journey to better. An unconventional start to this week's Physio Coach podcast. We're going to be drawing upon last night's Traitors finale, which will timestamp this somewhat, and we're not quite sure when this will be released, but we're in November of 25, the celebrity edition, and Alan Carr has just pulled the rug from underneath everyone and somehow managed to win it for the Traitors. And we were just joking about this off air and how obvious this seemed to us watchers, and yet how all of the other celebrities just could not see beyond Alan being a faithful, and yet to us there was so much evidence clearly showing that he was a traitor, but quite an obvious traitor, I would say. Liz Bayley, foot and ankle specialist, dance specialist. We'll start with Traitors.
Let's start with Traitors. I'm a massive Traitors fan. I've watched every single one of the English episodes, all of the international ones. So I love the psychology behind the episode. It'll come up in the podcast, I'm sure. My first degree was psychology. I've loved social psychology my whole life, and all the mentality behind games like this. And yeah, so I loved it and was watching, obviously, live. But yeah, there's definitely parallels that you can draw, aren't there? We were saying about how, as an audience at home, the production company completely manipulate what we see. So we get to see when someone raises an eyebrow, but unless you're looking at that person at that exact moment, you don't see it.
Yeah, exactly.
So that's where we're all going, it's so obvious, how could you not know it was Alan or Kat or whoever, or Jonathan? I thought Jonathan was more obvious. But we forget what we know. But it's that confirmation bias, I don't know. And we were saying those parallels between that and physiotherapy. In when you get a tricky case, sometimes it's hard to see the wood for the trees, or you just need to take a step back and look at it with a different perspective or reevaluate. But there seems to be some crossover somehow between Traitors and physio, doesn't there?
Yeah, well, I when I figured something out in physio, I'm often thinking, how on earth didn't I get that before? I'm like, but I obviously couldn't, because it took me that long. That's just how long it takes. But yeah, with that evidence presented to me, I can make the conclusion. But before that, I didn't have it. Just like the faithful within Traitors, they didn't have enough evidence available to them to make the decision. You also mentioned about this second opinion concept, and I think that's absolutely true as well. The amount of times people have come in for a second opinion, it's a much easier process because you already know what isn't going to work because they've tried that and it hasn't worked. So you can rule out things. You've got way less things to choose to do, and there often is something that's to some degree glaringly obvious because all the other stuff has been done. Whereas someone who has been in it the whole time, the faithful who have been in that manor house the whole time, seeing Alan being funny and hilarious and jovial, and he couldn't be the traitor because he wouldn't can off his best mate Paloma in the first episode. It's like they could not see past that point. And there he was at the end, and he won it.
Yeah, that's also similar, I think, when you have a patient come in and they say, oh, this is what my diagnosis is. That's like a nightmare. And I've learnt the hard way. And if anyone says to me, oh, I saw someone else, this is what they say, I always stop them now because it will bias my thinking. And the case where I got that wrong, it was an ACL. And the patient had been to A&E, had all the x-rays done, etc. And they said, oh, there's nothing wrong, it's the MCL. And I thought, oh, well, they've been to A&E. This was a while ago. So I'm more experienced now. Obviously, you learn from your mistakes. And I was thinking, well, the mechanism of injury suggests ACL, but she's seen A&E. They're happy. It must be MCL. And then as her rehab was progressing, the instability was there. And I was starting to get a little bit suspicious. In the end, it didn't matter because those things aren't necessarily urgent to diagnose and treat immediately. But I missed the diagnosis for sure because in my head, I didn't need to assess it because it had already been seen. So I've learned from that. So now I try not to get diagnostic information from other people before I get some of the reports, and it's hard because it's often on there, isn't it? Yeah. But definitely hard not to be swayed by someone else's diagnosis. And then because often I see people for second and third opinions. Sometimes you're presented with all the information and you just say, right, let's go right back to the beginning. Let's just start again. And I think for the patient, it can be frustrating because they'll have told the story 15 times.
I was just about to say that.
Yeah.
And that's why nowadays I say, look, I know you've told the story many, many times, but for my process, for me to be as effective as possible, please can you tell your story from the beginning? I think that's really important, just to almost set their, or appreciate their frustration, acknowledge that, I know that you've told this story many, many times, but I'll be hearing it for the first time and I'd love to hear that story.
Yeah. Yeah. A good example of that is where somebody came to see me about, it was a sesamoid case, so it was sent to me as a sesamoid case, but it didn't present exactly like a sesamoiditis, and I was thinking, and they weren't getting better with the treatment. I was thinking, well, what else could it be? And I was like, let's go right back. I was like, okay, take me back. When did this start? And they said, well, it started then. But about 6 months before that, I remember now, there was this weird thing. It's always the same story. So heads up for anyone listening who sees feet. They say, I was at a wedding dancing in heels. That's one of the classics. And they woke up the next morning with a bruised, swollen big toe. And I was like, 4 to 6 months before they had their quote unquote sesamoid pain. And in the end, that led me to think, something has happened to that capsuloligamentus structure that isn't just a sesamoid. It's not just an overuse injury. There's some kind of trauma that's gone on there. And it turned out it was a degenerative plantar plate issue, and there was a long-term instability issue. So if you treated it, it might have recovered with really good foot strength, but there was an inherent instability in the big toe, and because it's such a shallow joint, this was a high-level athlete, it just wasn't coping with the load being put through it, and it ended up that needed surgical opinion. So very different from a sesamoiditis where you've got a bony overload and you just have to pull back and rehab them where there's no instability. But because they were 6 months apart, I can't remember, it was about 4 to 6 months between when the actual injury happened. Of course, she went to A&E, x-rayed it, nothing. And then she's just treated as, I've just hurt my big toe. And I've had 3 cases like that in the last year. It's very similar onset, it's very similar types of patient. They were all hypermobile. So it's this degenerative hypermobile big toe, which has a lot of load put through it, plus or minus alcohol. They're not always drunk. But that's the key to the diagnosis, because otherwise it does look like a sesamoid case, but then you miss the instability.
I've got a couple of things on that, actually. Firstly, how often does someone dance around in heels in their life? Right? So,
apart from me, I did it for 15 years.
Well, there we go. So we can come to that. But how often does the average non-dancer do that, right? It's a very unusual thing to do. You might wear heels and walk, maybe you climb some stairs here and there.
Yeah.
But that's a really unusual activity to perform. So it makes sense that that's a high-risk activity, actually, for most people who aren't dancing around on stage in heels.
Yeah, although some of them were dancers, actually, but I think it was the length of time and the shoe type, because dance heels tend to have a bit of padding and they're quite supportive, whereas going out heels don't have padding and they tend to be less stable, and you're on them for way longer, like 7-8 hours in the day, aren't you, if you're at a wedding? So I think that's the difference. Yeah.
I'm just also reflecting back to our wedding where we had a basket full of flip-flops, and so if you end up at a wedding and there's a load of flip-flops there, take them up, otherwise you might end up in A&E with a plantar plate.
Yeah.
The other part of this plantar plate conversation, I think, is almost the opposite of what you're describing there. My first exposure to plantar plate injuries was in rugby, the front row players in rugby, and I know a player that I helped rehab who had torn his plantar plate in the scrum. So not so much a hypermobility, more of a massive force going through one very small area on the foot. So that's probably the other end of that spectrum, isn't it? The suspicion would be there for me, if anyone is a rugby player, certainly someone in the scrum, that if they're getting that pain on the bottom of the foot, I'd be quite suspicious of that there as well.
Yeah, for sure. The big difference is that one is acute and the other is degenerative, and that's why the degenerative ones get missed, because the acute one, most people would realise something's torn or something like that. But because it's such a mundane mechanism of injury, did you do anything? No. I was at a wedding, So that's definitely why those ones get missed. And those are the ones that end up being really tricky, really chronic. The instability is a massive issue, and they either end up needing surgical opinion, or there are some other therapies you can do, actually. Because I've seen a few of them now, I've learnt about it. I didn't know about, you only know when you see these tricky cases. So with one of them, the healing meant it became sort of calcified. So the plantar plate had calcification on ultrasound. So what she was being treated with was steroid injections. And we know that calcification responds great to steroid. So she would have an injection, be completely pain-free for 5 months, and literally on the date that it wore off, she'd get pain again. And I can't remember how many she'd had. It was a lot, as many as 4 or 5. And she said, well, I can't keep having steroid injections. Clearly, we're not getting to the bottom of the issue. And that was when I referred her. I took her on, hadn't identified the instability yet. This is the case. Rehabbed her because there was weakness there. We were like, let's wait until that window when the steroid wears off. Let's just see if this works. And I was like, please work. And about a week or 2 went past. She said, the date's come and gone and I feel okay. And I was thinking, yes, we've done it. And then it came on slower. So it won her some time and it was less severe, but it did come back. So I referred to a sports doctor who ultrasounded it, found the calcification. And then we were umming and ahhing about, well, what do we do now? You've got this unstable joint. We don't really want to do surgery. So we sat on it for a while trying to think, what do we do? So we looked up the options. One was prolotherapy, potentially, to try and basically like stick it back together.
Yeah.
Kind of therapy that's done for like Achilles tendon splits, isn't it? But there's no evidence for that really. And the sports doc I was working with had to say to the patient, look, we could try this, that I have no idea if it'll work. Or we can keep doing steroid injections. And she wasn't very happy with that. She just said, well, I just don't feel happy doing something where you have no idea. We also said it could make you worse. It's such a gamble. So again, we sat on it for a while and I was thinking, what can we do? And then I did a shockwave therapy course previously. I'd already done it at this point. So looking at the evidence for that, I was looking through it for something else and it said calcification of tendons. And I thought, oh, that's that patient. I wonder if focus shockwave therapy might do something. It's lower risk than something like an injection. It was also cheaper overall. So we wrote to her and we said, okay, these are your options. Surgical opinion, prolotherapy, focus shockwave. We recommend go focus shockwave first, probably 3 or 4 sessions, quite low intensity, and then build up and see. We did that. She's now had 3 sessions. It was here until actually I referred to someone else to do it. And so far, it's brilliant. Her pain is reduced and she's doing really well. So now we have to rehab her again and see how she copes. So I don't know how the story ends.
I'm really interested by rehabilitation for an unstable big toe. What are the kind of things you'd be thinking about there?
Okay, so rehabbing the toes or the forefoot is something that when I look across when you look at what everyone's doing, and I know this because I teach a lot of courses and I see patients' second opinions and I have physios shadow me. So I know kind of what gets done for the cases that we see. And I say to my patients, what rehab have you done so far? And generally what's given to patients is picking up balls with the toes, so like marble picking, or grabbing a towel, or short foot exercise, or what else gets given? Any kind of balance. It does rehab the foot. But in general, I've never had someone come to me. Oh no, the other one was banded big toe work. So that is very specific to the toes now, and at least we're adding a bit of resistance to it. So banded toe work, I'm always like, okay, this is on the right track. But I've never seen anything more than that. Anyone that's been referred to me, and I work with pro rugby, pro football, obviously pro dancers.
Okay, good. I feel better.
Okay. Yeah.
So that's probably about as far as I could get to be honest. Maybe some isometrics on bent knee forward. Yeah, that's probably as much as I can consider. But load bearing isometrics.
In what position?
Probably in a bent knee position, offloaded body weight to begin with, but specifically with big toe driving down through the ground.
Okay, so like a calf raise.
Calf raise, isometric, bent forwards. Yeah.
Yeah, good.
With an intentional big toe flexion.
Yeah, that's great. So that is exactly the kind of position you want to be in. But what you can do to bias that and make it more foot targeted rather than calf targeted is just extend the toes. So we know that the foot will produce the most amount of force with the toes in extension. And that's to do with the force length relationship between the extrinsic and the intrinsic muscles. The intrinsic muscle's job is to stiffen the forefoot for propulsion. So it's not actually to raise the arch or to stiffen. It does stiffen the arch, but actually the tib post does a lot of that work as well, and tib ant. And the intrinsics are much more about MTPJ stiffness. So that's exactly what you're talking about, isn't it? So it's that stiffness going into extension with flexion. So extension, but with flexion. So, I mean, I've only really known these levels of sort of foot strength probably for the last 5 years or something. And then in the last 3 to 4 years, there's been a bit more about it in the literature and people talking about it on various different educational platforms. One of the main contributors to this space, who I follow a lot of his work, I teach a lot of it, is Romain Tourlon from Switzerland. So he's done a PhD in forefoot strength. I think he's just got his PhD and he's starting to publish more research. And his work is so useful because it's not many parts of the body that we don't know enough about. We could always use more research, but the foot is so neglected. Like the ankle's pretty good, Achilles is pretty good, but actually the foot itself in terms of physio, there's not really anything. Like there's a bit about, but it's always to do with foot posture. So if you look through the research, the last 15 years of foot strength research is to do with foot posture, not really pathologies, a little bit, but it's always related to pes planus. So they're always like, pes planus is bad. How can we improve the foot posture? Does that improve pathologies? We don't know because we didn't really look. So that's very general. There's a few more specific things, like plantar fasciopathy's had a bit of research done with it. Rathleaf is the paper for that, 2014, which is still relevant now. But even in that particular case, now that is exactly what I'm saying. It was a toe extension calf raise with the heel dropping off a step, which most physios know that as the plantar fascia exercise. And that is, I would absolutely agree, that is a great exercise for plantar fasciitis. Now, we used to think that was because of the way it tensioned the plantar fascia. But actually now we know a bit more about how the foot works. It's much more likely that works because it's the perfect way to strengthen the foot.
Am I right in saying that the Dylan Morrissey group, they're at QMUL, did they then come out with another follow-up review that suggested that actually stretching is really good for the plantar fascia and that loading it is not as good as we thought it was? Is that right? Am I remembering that correctly?
Yeah, that's the 2021 paper, isn't it? So it's the clinical recommendations or the clinical practice guidelines. Yeah. So it's a really good paper, really thorough, amazing group of clinicians that did it. It's not quite what you're saying. So the recommendations, if I off the top of my head, it's taping, education, load management, stretching. I think that's those 4.
And I think it was the stretching in particular that caught my eye, because it was at the point where I was thinking, stretching doesn't really work for most people. Occasionally it will work, but I wouldn't have expected to see it in a clinical practice guideline.
As recent as 2021. Yeah. So when you look at it, and I've spoken to some of the people that were on that paper or know the team that did it, the only reason loading's not in there is because there's not enough research. It's because there's not enough good quality research. So that paper only pulled the good quality studies, and there isn't any, which is mad. So I think in the next 5 years there will be.
Okay.
And I think when they update it, loading's going to be right at the top.
Glad I didn't stop doing it then.
Yeah. No, absolutely. Load is the way forward, but also it depends on your patient. So plantar fasciopathies hit 2 types of people. It's either very active or very inactive. Yeah. So if you have a very inactive person, if you stretch, tape, load management, they probably have a reasonable response to that. If you've got a really active person, they might not respond as well to that. You have to offload them somehow before you load them, or load them more strategically. So with any kind of foot issue, footwear and orthoses are massively useful because they can change the load that goes through the foot.
Tape, it's the thing I use tape for more than anything else, maybe other than perhaps anterior knee pain. With K-tape I use that reasonable amount, and ankle sprains, acute onset ankle sprain or acute onset calf, try and just essentially boot it to some degree, but with tape. But yeah, I use tape all the time, plantar fascia pain. I think it's a really effective short-term offload strategy.
Yeah, and it's evidence-based, definitely is. So there was a paper, I mean, often people use rigid tape. They do a stirrup around the heel and then strips across. But there was another paper done recently which compared rigid with flexible tape, and actually the flexible tape had better outcomes.
Oh, wow.
Yeah, I mean, I use flexible tape more than rigid actually because of the populations I work in. Knowing it's not really going to change anything mechanically, but it feels great, and that's what I'll tell people when I tape them. I don't say this is going to stop you from rolling your ankle. I'm going to say this is going to give you a bit of support. It'll help your confidence. And for the first half hour it's on, you'll really feel it. You probably won't feel it after that. And it might help mitigate your risk a little bit for various different reasons. Always talk about proprioception. So I'm a bit more of an advocate for the flexible tape for that reason. But it was interesting when that study came out. I can't remember who the people were that published it.
Yeah, I also call it like a hug for your foot, or a
Yes,
hug
I
for
say
your
that.
knee.
Yeah,
Because that's what people say. It's like, oh, it feels really good.
it feels like it.
Yeah.
If you tape, so if you just, my favourite foot taping is if you just take a strip of tape, fold it in half, put the middle bit on the, like just below the Achilles, and then put each side of it down, one down the lateral side, one down the medial, but stretch it and put it under the arch on each side. It literally feels like someone's doing that to your foot. So it feels like the short foot exercise.
Yeah.
And if you do a couple of layers of that, when the person stands up, I don't think we'd have to check it. I don't know whether that changes their navicular drop. It's only flexible tape, but it feels like it does. There's that pull and that tug, and it makes people love that taping. So I use it all the time. It's very useful.
We should do that after the episode. Actually, we'll try and replicate it. And
Okay.
We'll take a video. Your expertise within foot and ankle is already coming across very, very well. So can we go back now? How did you end up getting into this world? What was the starting point for that?
Into the foot and ankle world.
Yeah.
So I'm a dance specialist physiotherapist and a foot and ankle specialist, but one was very much born out of the other. So the reason that I specialise in foot and ankle is because I'm a dance physio. Anyone who works with dancers will see foot and ankle issues half of the time at least. The other areas that dance physios see a lot of is hip, and what was the other one? Anterior knee pain, patellofemoral pain, a posterior ankle. But on other parts of the body, they're the kind of areas that you get the most in. Then you have to have a good knowledge of bone stress injuries for obvious and maybe not so obvious reasons, and hypermobility. So I kind of feel like I specialise a little bit in all those areas, but that's because they're subsets of dance physio. We recently did interviews to find a dance physio for something, and I was on the panel, and we set it up. I said they have to say the words hypermobility and bone stress injury at some point in the interview, otherwise they don't know what they're doing with dancers. It's such a huge part of what we see. So we set up 2 case studies, and both of them could have been influenced by both those things. And there was only one participant that got them, and they ended up being the strongest overall, actually. But if you really work in the dance population, you see it all the time. So it's just so prevalent, so knowledge of that, the complexities behind it, and then how to manage it is really important.
Can we go there?
Yeah.
They seem 2 pretty good conversations to have based on what you're describing here. So yeah, you pick whichever subject you'd like to explore first.
Oh God. Well, hypermobility. I mean, interestingly, I listened to your podcast with the Hypermobility HQ. Is it at
Alex. Orphanides, yeah.
Yes. I saw, and that's actually how I discovered her, was on your podcast, because I think it came up on your feed, and I loved what she was saying. She's everything she was saying. Yes, I was thinking, yeah, that's exactly what I see or what I think. She was talking about diagnosing EDS and how hard it is.
Yeah, she's actually just about to release a new series, so I'll plug that right here. Is that she's about to release a new series on her podcast? So Help Me, I'm Hypermobile, I think it is. So yeah, she's great. She's clearly a specialist and expert within hypermobility.
Yeah, and she communicates it very well. Yeah. And she's one of those people, when you listen to her talk, she's very calming, isn't she? I aspire to be like that. But yes, just interestingly, I'm speaking to her on Tuesday about a patient of mine, because I thought it's someone who I've been seeing probably for 18 months. She's an ex-dancer, has had issues also with bone stress injuries and disordered eating and amenorrhea, but the biggest problem now is her hypermobility. So she's been checked overall, she's had DEXA scans and blood tests and everything, and all of that is settled now because she's in her late 20s, but she is plagued by issues which I think are connected with her hypermobility. She's got a Baton score of 9 out of 9. She fulfills the EDS criteria, and then recently spoke to someone, like literally took the criteria and said, look, this is me, can you please give me a formal diagnosis? I think the trickiness in that is that you sort of need blood tests to be done to rule out other issues. Otherwise, you can do it clinically. And she's now got a diagnosis of EDS. But she is very reliant on exercise, let's put it that way. Probably a little bit dependent on exercise. And I think that she has that kind of personality, which is probably mirrored in her history of disordered eating in the past as well, and now it's more about exercise, and if she can't exercise, it really affects her mental health, and she's very fit, and does a lot, which means that she's getting injured a lot. And if it's not one thing, it's another, or we'll just get her back to something and then something else goes. So I see her regularly, I have seen her for 18 months, and I think she struggled to find someone who understood her body, but more importantly, was able to explain to her what it was or what we think it is. And it's been a really good relationship, but I feel like I just need some help because it's ongoing. She hasn't got any other support at the moment. We can't find a sports doctor that can be available to support her as much as she needs. And I immediately thought of Alex, and I thought I'd love to run her case past Alex and just see if she's got any pearls to help me with management or referrals, or potentially to refer Alex over. But we're basically going to talk and see if she thinks she can help, so that she can maybe come in and do a couple of sessions with her. So again, it's that different set of eyes.
Yeah.
You know, because I've seen her for 18 months now. I think I've figured everything out that I can. I'm sort of at the limit of what I can offer her now. I always find a way to help her. Whenever she comes on, I think, God, what am I going to do this time? What's it going to be? Where can I refer? How can I help her? And I always find a way to help her. I think she feels very supported, but I need some support now because it's such a complex case. So that'll be useful to speak to Alex on Tuesday.
I think what this is highlighting is the importance of maintaining a good MDT around you and curating a network of people that can support you with different cases. Mm-hmm. And I've spoken before on this podcast about how isolating it can be early in your career when you feel like your job is to help everyone and you want to help everyone. You kind of came into this career to fix everyone. But what is most important is the acceptance that you can never know everything and you will never be able to help everyone, and to find people that are close to you that you can trust and lean on to share clinical cases and share ideas and learn. Have a team around you, or have people you can at least speak to, because that's exactly what you just said. You consider yourself a specialist in this area, and you have people around you that you work with, right? I don't think at any point you will know everything, therefore find the team.
Yes, which is equally important for bone stress injuries, isn't it? If we kind of jump to, I mean, there's loads more we could talk about with hypermobility, but for bone stress injuries, that is a presentation which has to be managed as part of an MDT, really. So we see it so frequently in dancers. I've got people that I refer to privately, and then I've also got people who I refer to within one of the dance schools that I work in. So we have counselling support, a nutritionist who can be sponsored by the college if needed. Like if the student's already in counselling, they get free nutrition advice, which is so useful. And then if obviously you've got their GP, which is always a little bit harder to access, not always, but sometimes. And then I tend to refer to sports doctors who I know that I can trust. Actually, a lot of them work at Pure Sports Med. Yeah. Sarah Rollins is one of them. Mm-hmm. I love working with Sarah, for particularly with some of the female athletes I work with. She's just got such an amazing knowledge of women's health, bone stress injuries. She's a whiz at ultrasounds. Yeah, I've sent her a couple of sesamoid cases and gotten her input on those. Or James Noak is at Pure Sports Med as well, isn't he? So I tend to work with one of those two. Also, Amal Hassan, I'd worked with in the past. She's brilliant for any kind of thing to do with women's health, bone stress injuries, energy availability. And Nikki Key is the other one. So she's an endocrinologist. She'll send me patients and vice versa, usually who have a history of disordered eating, amenorrhea, low energy availability, bone density issues, and then the onset of whatever kind of bone stress injury they've got. So the ones that you see most frequently, ones that I see most frequently would be tibial and metatarsal, both of which are low risk, depending on where it is, actually. So anterior tibia is high risk, but medial posterior tibia is low risk. Metatarsals are generally low risk, but the base of the second or the base of the fifth are both high risk areas. I've seen lots of navicular bone stress injuries, which are notoriously tricky to manage. Talus, which have been misdiagnosed as chronic sprains because it's right where the ATFL is. They say that's where my pain is. You push it, it's on the ATFL. What's there? The ATFL, it must be a sprain. And actually, no, it's a Talus bone stress injury. That's a good example. When I teach, I say that ankle sprains are overdiagnosed but undertreated. So
agree.
Yeah.
I was on Alex's podcast, which won't be released for a few months yet, but the title will be it can't be just an ankle sprain. You know, this concept of just being used to almost diminish this really high high severity of injury for many people. So yeah, I fully agree.
Yeah.
Overdiagnosed, undertreated. Yeah, very, very nice.
Yeah, I used to say they were overdiagnosed, and then ultimately, because there's so many secondary issues from it, they're massively undertreated, because partly because we don't take them very seriously.
They call it just.
Yeah.
You go to A&E, oh, no fracture, it's just an ankle sprain.
Yeah, they're probably one of the worst culprits for doing that. I understand why it's not a life-threatening situation, but the management could be so much better if they had a bit more time to deal with it properly there and then. So it's a shame, but yeah, the just a sprain thing it comes up on my course all the time. But probably the only time I'd ever say that is if it was a grade 1, like someone's just clipped their ankle, it's a little bit sore, minor swelling, that's it. That could be just a sprain.
Yeah, they're the ones where you do want to reassure the person.
Yeah.
Say, you're going to be fine.
Yeah.
No major structural damage here, a little bit, need to take a bit of time off, and then you'll be able to get back to normal fairly soon. I fully agree, but it's the ones where they're limping for 2-3 weeks, they've got a massive big hemarthrosis, they've got a big bruising all the way down the foot, and it's like you cannot downgrade that to a just. You have to respect it and
definitely
treat it appropriately.
But then equally, I get people that have had those injuries where, if it, let's say, I nearly said the words, it was just a sprain, because it was only capsular ligamentous damage. It was nothing extra. So you can kind of say that, but I don't mean, obviously, I'm not belittling it. But let's say, so that I can think of a patient who had a full ATFL and CFL tear. So it was a high grade or grade 3 ankle sprain. When they got their results back on the imaging, they freaked out. So they saw that they had this high grade or complete tear of 2 different ligaments, and they had a lot of bruising, a lot of swelling, and a lot of pain. So they were really, really worried about it. And when I saw them, they wouldn't put their foot on the floor. There was a lot of fear avoidance. So a huge part of my job in that case was almost doing the opposite and saying, look, I see this stuff all the time, and the ligaments can heal. That's the first thing. Yeah. They might not heal quite in the same way, but we do see, complete healing of torn ligaments at around 3 months post sprain, and then at 6 months it's even better. If we load you properly, it'll help, and all of that. And then saying, I see examples of people that have this exact injury but are still playing very high level sport. So if you have the right rehabilitation, I'm pretty happy that you're going to do well with this, but we need to get you onto it now, because actually the earlier we load you in the right way, the better. Yeah,
I think that is the key. It's that there is a nuance in between, isn't there? You don't want to completely disregard it as just an ankle sprain. You also don't want to cause the fear to stop them doing what they should be doing. You have to allow for some biological healing and protect it in the early phase. This is where I almost, in fact, I probably for every single one, I'll draw tissue healing, the different phases, and I'll get it out on a bit of paper, and there'll be a slightly different version of it each time. But it's this bit's bleeding, this is inflammation, this is where it starts to grow a bit of a scab, and this is where it will scar, and this is where we have to load it, protect it here. And that seems to be really powerful for people, because they go, okay, right, well, I get that. So here I need to be careful, and here I need to push. Yeah, exactly. That's our main job here. Calm it down and then build it back up again. Simple stuff. So that seems to be really helpful in the early stage of a biological tissue injury of some sort. If we think about the injuries you were describing, you were talking about stress fractures in some less common places. What are some other ways that you would pick that up? Because palpation skills are going to be key there, right? You've got to be really specific about what you're feeling and what you think might be going on. What else are you looking out for in those, the objective assessment, and maybe in the history that might start to increase your index of suspicion around stress fracture in those places?
Yep. So the main thing is that it is load-dependent pain. It tends to be linked with intensity. So the harder they load it, the worse it gets. And in the earlier stages, it might have a low sort of level hum, and then as they load it, it gets worse, and it'll kind of get better when they rest after. Then it starts to be more painful all the time. Then it starts to become painful at night. Night pain is one of the key things, because bone metabolism is higher at night, so that's when you start to notice pain. Obviously, it's going to be more progressed at that point. So night pain's important, load-dependent pain. One of the interesting things, if you look at bone physiology, is how long it takes for a bone stress injury to show up. So the osteoblastic osteoclastic cycle, it takes about 4 to 6 weeks for the osteoclasts to clear away the old bone. And if the osteoblast can't keep up with that, then you start to get this deficit inside the bone. You get these chemical changes, which effectively are nocivic. and then that starts to send messages up to the brain. So at around 4 weeks post significant loading or whatever it is that's causing bony overload tends to be when people start to notice their symptoms. So if you can ask them, when did it start? What were you doing in the 6 weeks leading up to that? Did something change 6 weeks ago? And often that'll help you. They'll say, oh yeah, I started, for me, rehearsing for a show, or we went from the rehearsal studio to the stage, because often rehearsal studios have a sprung floor, stages have steel floors. So actually the flooring doesn't make that much difference for bone stress injuries. It's an abrupt change. That's what the research shows.
This is the same in team sports.
Yes.
It doesn't matter so much whether you play on grass or 4G. It just matters on whether you change abruptly. So people who train on 4G and play on 4G, they tend to be okay. But all of a sudden they spend a few weeks on grass and they're more likely to have problems, and then vice versa. It shifts, isn't it? That's it. It tends to be which makes sense. Like, you get an exposure to it, your body gets used to it, your risk goes down, sudden change happens, you're not used to it, and then again, your risk goes up.
About 4 to 6 weeks later, you notice it. Yeah. So the timing is important. If you're catching it on the first go, obviously. If it's more chronic, that might be harder to identify. So load dependent pain, potentially pain at night if it's more progressed, some kind of increase in activity, usually higher intensity. Then you're looking at usually more pinpoint pain. It's not really diffuse. So people can say, yeah, it hurts here. The finger point test. I learned that from Lizzie Marlowe. I used to teach with Lizzie. I say used to. Hopefully we're going to teach together next year. I learned loads from Lizzie Marlowe. She's a brilliant practitioner, but she used to call it the finger point test. So say to them, where does it hurt? Show me with your finger. So they can usually be really specific. And because the foot is so peripheral and so superficial, that tells you loads, that location. Because a centimetre further forward or back can be a joint or a different bone or a nerve or a tendon. And with palpation, you can be that specific with the foot. And I always say I can't be that specific with the back. I don't say that I specialise in backs. I can certainly treat a back. But I could probably tell you I was on like L4-5 right facet, probably. But I don't know for sure. There's so much tissue there and it's so deep. But with the foot and the ankle, you can flex the toes and see the superficial perineal nerve, or you can move the joint and put your finger right on it. So you can be very specific with it. So for example, with the Taylor's bone stress injury that looked like it was the ATFL, she said it's here and it hurts whenever I land a jump. And she
sounds very bony.
Yeah, it does when she says that. Yeah. What else? So location is pinpoint. Usually you can palpate it, especially if it's foot and ankle. And if the bone is tender and everything else matches it, you've got to rule that out before you treat it as something else. Yeah. You might get swelling. So in something like the metatarsals, because they're over the dorsum of the foot, I had a second metatarsal shaft fracture, which is low risk. But the dancer had been dancing on point, and it depends on the foot shape, but it can put more stress through the second metatarsal. There's also some research to show that length of metatarsal doesn't correlate with bone stress injury, so I'm just going to add that. But in her case, it did. She had a longer second toe, which means her second metatarsal was longer, which means when she was on point, it was probably loading it more. But I think the key thing with the research is that you shouldn't use that to evaluate risk. So you should.
That's average, isn't it?
Yeah.
Whereas for an individual, it could be anywhere on that average calculation.
Yes, and it's so many other factors put together. So I wouldn't screen a dancer who had a longer second metatarsal and go, oh, they might get a second metatarsal bone stress, because it needs all the other factors to come together as well.
You can reflect backwards on it though, can't you? Just like we were saying with the Traitors earlier, you can reflect back and you can see it from a different perspective and go, okay, it was probably a factor for you.
Yes, exactly. So with that girl, when she came in, she actually wasn't weight bearing very well at that point. It was quite chronic because it had been missed twice already by 2 different practitioners. One told her it was just a soft tissue injury. I don't know who she'd seen. And they gave her a can of freeze spray and said, spray that on your foot before you dance. I mean, that is like next level, no clinical reasoning, and easy for me. I've made mistakes. So, but in that particular case, I was like, wow, that's like, it's a barn door one. But if you're not used to seeing them, I can see how it could get missed, and I saw her when it was more progressed, so it was more obvious, and I see them all the time. So for me, it's an easy diagnosis. But if you don't see that population much, I can see how it could be missed. So she had swelling over the dorsum of the foot, so you couldn't see her tendons, her extensor tendons as well on the affected side. She wouldn't put weight on it. When I palpated it, was pinpoint painful right in the middle of the shaft. That's all the stuff that I would be looking for. of course, if you ask about history, it's always ask someone if they've had a history of other fractures or particularly stress fractures. If someone's had any kind of stress fracture before, their risk of having another bone stress injury goes way up, because whatever that magic mix of risk factors is, because it can be everything, can't it? You've got environmental, you've got external, internal risk factors, so many different things. Whatever it was that made that person have the stress fracture the first time means they're at high risk of it the next time.
Which makes sense, because it would be incredibly hard for them to change all of those risk factors significantly enough to reduce their overall risk, right?
Exactly, which is why it outweighs any other risk factor. If someone's had a stress fracture before, they've got whatever that thing is that's made them susceptible to it. So obviously, if I'm suspecting a stress fracture, that I then go down the questions around bone health. So I always frame it very carefully, because I think if you just say to a girl, when did you start your periods? I don't think I'd have trouble, because I usually have pretty good rapport with people. And I think as a female, it's easiest to ask it. But I always say, look, I want to ask you about your general health. One of the questions is going to be about your hormone levels. To monitor that, I need to ask you about your periods, like your menstrual cycle. Is it okay if I ask you? And of course, that sets it up nicer for them, so it doesn't feel like it's quite so personal or potentially irrelevant. Like if you don't know, I wouldn't have known that before I did my training. Who cares if you get periods? Why does that matter why my foot's broken? But for us, we know exactly why we're asking it. So I say, do you remember when you started your periods? We know that anyone who starts their periods over the age of 13 and above, their risk of bone stress injury. There's one paper that was published, it was a while ago, I can't remember what the date it was, but they said for every age over 13, the risk of a bone stress injury goes up by 30%. So another third, because actually 12 is the average age for menarche, which is the beginning of periods. So if you're 13, it's a slightly high risk, but that's reasonable. 14, you start to think that's a later start. 15, definitely higher risk. 16, much higher risk.
Why is that, do you think?
It's to do with the bone health, the levels of hormones as the bones are developing, and the estrogen. That's the most technical answer I can give you. Nikki Key could give you a perfect answer to that. Yeah. I just know that it makes a difference as to how your bones form and
I didn't know that.
Bone health. Yeah. So it's a useful one to know. So if they started later, like sometimes they'll say, oh, I started about 17, and I kind of go, oh, that matters, you know? And then you find out, or did they even start their period? Sometimes they don't. And sometimes they didn't start their period, so the GP puts them on the pill, and then you don't even know if they would ever have had a normal period. And you're seeing them age 24, for example. So getting all of that information is really important. Then it's lots of information, but I'll go into it. If they have started their periods, you want to know, were they regular? Do they ever get less than 9 a year? Because that could be significant. So a little bit less than 12 a year might be okay. Less than 9 is definitely an issue. Have they ever been on hormonal contraception? Why? Were you on it actually for contraception, or was it because of your skin, or was it because you have very heavy periods, or was it because your periods were really light and they wanted to regulate them? Because that happens all the time. So all of that information will let me know if I need to make a referral. I'm not going to do anything else with that, but it also raises my index of suspicion. Then and for boys, so always focus on females with this, but of course we know men get bone stress injuries. And I recently had a young, healthy, fit male who had a midfoot bony overload presentation. So there wasn't a fracture, but on the MRI there was bony edema. And he admitted to me, he said, my gut health hasn't been very good, and I think my testosterone is low. And I said, what makes you think that? And he said, oh, just the way my body's been. And I thought, I've got to ask him. So obviously you have to, it's easier to ask women about periods. It's not quite as explicit as asking men about their sexual function, but you've got to do it. So I said, look, I need to ask you a couple of questions. It's to do with your hormone levels. So I said, have you been, well, one was fatigue. He'd been feeling very fatigued. Yeah. And he said about his low libido. So he offered me that. And then I said to him, have you had any trouble gaining or maintaining an erection in the mornings? And he said, yeah, that was the other thing that triggered it. So he sort of knew. But it's so important to ask men that, because it can easily get missed. So yes, so there's questions around that. And then I would always ask about diet. I mean, that's a whole other section, especially if somebody has any issues with eating, any disordered eating history. If you ask them about food, they're likely to just clam up. So I always ask very carefully. I say to them, do you eat everything? And then I quickly say, are you a vegan or a vegetarian? So I don't say, what do you eat? Which is such a triggering type way to ask it. I want to know, about your sort of choices, I guess, more. There may be a better way to do it, but that's kind of how I've started doing it. So I say, you vegan or vegetarian, do you eat everything? And then if they ever say to me, oh, I do, but I eat very clean, that's a bit of a flag for me, because it means...
What does that mean to you? Yeah.
Exactly. It's kind of like the new way of saying that you eliminate food groups for whatever reason. So that's something that I would be aware of. Mm-hmm. And then I'd start to try to get a bit more information. I do sometimes say, do you eat 3 meals a day, or do you skip any of them? Often women skip breakfast. And then I say, do you eat snacks? And if they're being honest, sometimes they won't be honest about it. So I ask about snacking, and then I ask about what else. And that's important for women. It's so important for young men. So in a lot of the shows, we're in Soho, so I worked on all the shows in this area. So literally every single one you can think of, and a lot of them have young casts. So the main part of the cast is often made up of like 22-year-old male and female performers. And often I'll speak to the boys about, doesn't matter, not necessarily a bone stress, but some other injury. And we get onto the subject of food, because let's say we're in a rehearsal period and they've been in the theatre since 10 o'clock that morning. It's already 6:30 at night. And I say to them, have you eaten today yet before you do the run later? And it just comes up in conversation. So often young males who like are on their first or second job from either college or moving out from home aren't great at looking after themselves, and they accidentally underfuel. So loads of them go to the gym, which is fantastic, but then they're in rehearsals during the day, gym, 2 shows at night, for example, and they've eaten maybe once because they forget, or that on what they eat isn't that good, or
so it's more like an accidental red situation, isn't it?
It happens all the time.
Like I'm trying to lose weight, trying to maintain my physique for whatever they're on, or it suddenly becomes like, oh yeah, I didn't really realize how many calories I was burning, and didn't realize that the gym needed proper fueling, and that there's lack of knowledge and lack of awareness and time and all those things. So that's a really interesting point, one that perhaps because you're in that world, you've got a real kind of front row seat to that experience. But I'm not sure I'd have thought of that until now. Yeah.
And the other one is girls who know that women are meant to eat about 2,000 calories a day, but that's just to survive.
Yeah, let alone to dance and perform often twice a day.
Yes. So. This has come up a few times. So again, it's that unintentional low energy available. They're like, but I eat 2,000 calories a day. I said, but you've been to the gym, you've done a rehearsal and a class. Like there's dance studios here. Some of them will do class, then rehearsal, then gym, then the show. That the load they're putting on their bodies, and they're young, so they're so resilient. Some of the guys, they get in, like one got a groin injury. In 24 hours, he was back. They're so fit and healthy. They get better. They're very resilient until they're not, So it's useful to screen for that stuff and help them realise how important that is. I mean, for some, particularly actually for the Lion King cast, we had, in any show, you get bone stress injuries. That show is very jumpy and the stage is made of steel. So we used to get probably a couple more bone stress injuries than you might on other shows. But if you've seen the show, it's a very sort of multi-ethnic or racial cast, and a lot of slightly darker skin tone. So we had a conversation about everyone just taking vitamin D, because we just thought that was there's research to show take vitamin D and calcium, risk of bone stress injury drops. Sleep is the other one. In military recruits are the ones that a lot of the research is done in, because they get so many bone stress injuries and they're there, they can do research on them. So vitamin D, calcium supplements, sleep. If you can get some of that right, you're almost certainly going to reduce your risk of bone stress injuries. So that was a conversation we had at one point. We said to everyone, we want you to take supplements. We want you to start prioritising your sleep a bit more. That was in rehearsal period, because again, they're young, they do all that and then they go out clubbing all night, Some, not all of them, some of them, but we just thought it was worth having a chat just to say, don't forget how important sleep is. A really nice example about like how I'd spot a bone stress injury. I said, always look at load. What have you been doing? Have you started like training for a marathon? Have you started plyometric training? Have you suddenly started playing basketball or something? I had a patient who had what looked like a navicular bone stress injury, and I was thinking, but they were in a show I was on, so I knew them. I knew what they'd been doing. Nothing had changed in a year. And I was like, why now? I was like, what could it be? And I said to them, how's your sleep been recently? And they said, oh, it's been terrible for about a month. We've got rats in our flat. And I was like, that's it. So I couldn't figure out what had changed. They'd been in the show for a year. Their body was completely used to it. There was no reason for them to get a bone stress, but their sleep went a month ago.
As you said earlier, bone metabolism highest
That's it.
in sleep.
I was like, it's so satisfying. I was like, thank goodness that makes sense now, because I couldn't figure out what had gone wrong. So we just needed them to sort that situation out. We pulled them out of some of the jumpy things, a little bit of rest, because you have to be careful with navicular bones. But because I see them so quickly, like that's not been festering for a month. I saw her like 2 days after it started, and she said, this part of my foot's a bit achy.
Finger test.
Yes,
point test.
fingertip. Yeah, exactly. But because I knew her, that's that thing where you've got the benefit of knowing someone's medical history. I also knew she'd had a history of a bone stress injury. That was really important. So I was like, okay, are we going down that road again? But I couldn't figure out why, but it was her sleep. So useful.
So you've been on all of the shows in Soho, one way or another. I know you spent the most time on Lion King. What do you learn from an experience like that when you spend, multiple years on the same show? The cast will obviously change, but you spend a lot of time with the same type of individuals. What kind of learnings do you take, and how did that then progress your career towards the specialist role that you now have?
Yeah, so I did Lion King for 3 years. I did Wicked for 3 years too. But I was a sports therapist on Wicked. So I was a sports therapist before I was a physio, which is how I have like 15 years experience. So I did about 5 years as a sports therapist before I became a physio. So obviously I was working at a lower level then. The reason I did my master's in physio was because I wanted the sort of more intensive training and better knowledge and be able to diagnose and all of that stuff. So yes, it's been a long time. One of the things, people don't expect this with big West End shows, it's not always that easy to refer out or to get imaging. So you would think it would be like a sports team where you're like, right, MRI, done. But it often isn't, for lots of various different reasons. And so one thing that has to be really good is your clinical reasoning. And actually you spend quite a lot of time in quite isolation. So you're not there with a team of people. It's just you, like either in the company manager's office, because these theatres aren't that big. So at Lion King, I was literally in a cupboard under the stairs. And after 3 years, they moved it into a room, which was further up because they realised they were going to keep it and they wanted to give them an actual space, which was really good. At Wicked, I was in the company manager's office because theatres are huge, but every room is taken. So the company manager would be working away and I'd have a little table in the corner and then the cast would come in. But so that you don't have a lot of resources. You don't necessarily have an MDT. You do, because often, when I was in both of those jobs, I actually worked for companies. So it wasn't me as myself. I worked with a physio company for one, and actually it was an osteopathy company for the other. So you do have people that you can talk to about cases, but you're not all together in the room together, So I did feel quite isolated, and if you had tricky cases, you couldn't just quickly ask someone for help. So you have to be quite good at just managing, good at making decisions, and you have to be good at making decisions because you're making decisions that make a huge difference to who's going on stage that night, and that can affect the whole show. The biggest thing that happened was the principal of one of the shows couldn't go on, and I had to decide whether they were fit or not. But if they didn't go on, the show would have to close that night because for whatever reason, their system of understudies and things wasn't going to work out. So it was a really big deal. So that the shows all have understudies, standbys, and swings. So they're different level of cover for all the different people because they have to be able to cover people if they're sick or injured. So it's a very professional setup. Very rarely does anything like that happen. But in this one particular case, I think it was around COVID, so more people were ill. And they said, well, either she goes on or the show has to close, which is a huge thing. And it was my decision. It is. And I had the company manager, I had the production manager, the director, and I was like, I just don't know what to do because really she shouldn't have gone on. So I'm not even going to tell you what happened. It was a whole big thing. We worked it out in the end. But you have to be able to, it's quite a lot of stress. It's a bit like being sort of pitch side, for sports.
I've got that experience myself as well. And I would say on the whole, you take a risk and things go okay. But I've definitely had situations where I've made a call and it hasn't gone well. I've made a call and I've decided, okay, between us, we're going to take this risk. Everyone is aware that the risk is there and they get re-injured. I've definitely had that. And you feel terrible. But no one looked at me and went, oh, it was your fault, because we had the conversation at the start and said, this is the risk we're playing with here. What's the decision between the team? And it's the player, it's the coach, it's the other part of the medical team. Sometimes you haven't got another part of the medical team, but yeah, you have to make a difficult decision, and ultimately it's up to the player in the end, really, isn't it? The player gets to choose, it's their body.
I'm so glad you said that. I always say that.
Yeah.
Because I think sometimes you hear people talking and they're like, you know, I took the player off or I told them they couldn't go on. And you think, well, yeah, maybe you did, but there's far too much power in that. So you have to be the person that helps advise the person what's the best thing for them to do in the situation. It's got to be their decision.
Yeah.
It's never your decision. You can say, it happened to me on one of the shows where it was one of those, like, they'd had the injury, it was a hamstring pull. And I was like, that's going to go again. We know they re-injure really quickly.
Yeah.
I thought, I was doing a bit of massage thinking, oh, they really shouldn't go back on, but they really wanted to go back on. And I thought, don't be over cautious. This is their job. They don't want to come off. They lose money if they don't go on stage. Sometimes it depends on the setup.
Yeah.
But I really didn't want to be, it's too easy to just pull someone off sometimes, you know, but my heart was saying to me, my head was saying to me, don't let it go on. And I thought, it'll be all right. And I kind of crossed my fingers and I was like, please just get through the show. And at a certain point, there was a phone call. I thought, damn it.
Yeah.
She's done it again. I knew it was going to happen, but I still, again, I don't want to say I allowed her to go on. I still said to her, you should be okay. Just be careful on this, this and this. I knew she was going to pull it again. You know, I should have been maybe a bit more careful with it.
But you do learn through experience from that.
Yes.
Because there are certain injuries now that I am a bit more forthcoming with my opinion. Look, I've seen this happen, and I'll say it. I've seen this happen before.
Yeah.
I allowed it to happen. They ended up re-injuring. So you are much higher risk with this particular case here. So I think that inevitably we have to learn through those experiences, but you're not going to be a physio that is, certainly in that high performance environment, you can't be a high performance physio unless you take risks with that, because they won't tolerate it. The staff won't, the players won't. They will just be like, this, they don't know what they're doing. Like, we can't have this. There's no one available for it. We've called off the game because everyone's injured. It's like there has to be an element of risk taking. You just get really good at communicating, so you know that everyone is involved in the decision, and you get really good at deciding what that risk profile really is. Is this low risk, high risk, medium risk? So I think that's what I always took from those situations. Like, you can feel really terrible at the time, and I definitely did for a few that have not gone so well. But they stick in my mind so clearly now that I know that I learned a lot from them.
So what you said about the communication, that's one of the key things. So with shows, you have the production, like the artist side, and then you have health. So you've got to somehow communicate between you to make this happen. And what in ballet companies, so we're not far from the Royal Ballet, which is probably the best set up in the whole world in terms of the medical facility, the everything that they've got. So Lion King is 3 minutes down the road from Royal Ballet, and now I was in a cupboard under the stairs with some tape. The level of dance was the same. Those performers in all of these shows, they are so talented. Been training since they were 3 years old, like I did too, because I was a professional dancer for 15 years. I'm not saying I was as good as the Royal Ballet; they're better. But yeah, that communication between health and the artistic side can be really tricky. You have to really good people skills, clarity, clinical reasoning helps, because if they can understand why someone shouldn't dance, like a bone stress, you really can't let them go on. Whereas if it's a tendinopathy, yes, you could, you know. So being able to explain clinical scenarios to non-clinical people is important too.
What tends to happen in those situations is, if certainly early on, if you get a few of those right, you build a huge amount of trust, and they then start to trust your word way more than otherwise. I've definitely heard people who haven't had that positive environment where they've really struggled to work with coaches and players, but I've been very lucky in my career. I've always had good teams around me that have trusted me. So I think that all I can say from that is I've been lucky for one, but also that I must have communicated well enough for them to trust my judgment and for things to go the right way.
Yeah, The Lion King was the first West End show to have a full-time physio. That was 2021.
Wow.
Isn't that mad?
Yeah.
So West End shows have had physiotherapy input for many years. I did it 15 years ago when I was a sports therapist for the physio companies, etc. So it's always been there, but the people would have to go out of house to get it. So they either go to the physio company or we would go to them, but say for 2 nights a week rather than full time. So I'm pretty sure Lion King was the first ever show to do that. So, you know, congratulations to Disney and it was actually an American dance. She's called the dance. What's her actual name? Dance coordinator. But she's the one that came over from America and said, I want a physio here full time. This is a hard show. We need input. So really, like, well done to them for being the first to do that. But the problem was, and once we were in house, is that people came to see us, and actually people were taking more time off. And they said, since Physio's been here, we've had more problems with attendance or performance than before. And it was meant to go the other way around. Now, remember, I went in after COVID. So it was an absolute storm of, you can imagine, everyone had been off for 2 years. No one had jumped. Everyone was deconditioned. So it was not a great time to go into a show. It was a very good time to learn about injury risk, and I learned a lot from it, but it was probably the worst possible profile for injuries you could have for various reasons. So of course people were more injured anyway, but it was an interesting conversation with the production company, because they said, look, you're meant to be here to help us keep people on stage and this and that, but that takes years of coordination for people auditing what are our injuries, putting things in place to stop them. Me being there wasn't going to make people not get injured just because I happened to be there. Of course, you're still going to get the injury. So it became very firefight.
You can't catch it in the moment, can you?
No, you've got to. And I know from working, like when I've taught with like the army, for example, and teams that have been there for 6-7 years, and they're like, now we're getting somewhere because we've had time to audit, speak to the bosses, say this is what we need to put into place, and get that in place, re-audit, what do we need to change? And you can see the injury rates dropping when they're able to do that. And I think they had the right idea, but there was no way it was going to happen by just someone being in the building. In actual fact, it got worse, I think, before it was going to get better. And I left after 3 years, so I didn't get a chance to implement some things that I wanted to implement. But we're definitely going in the right direction in musical theatre. It's coming. We're just 20 years behind ballet.
And ballet's probably a bit behind other sports as well. You know, other sports have been doing it even longer than that, although not necessarily all very, very well. But there's been a culture of physio being within sport longer than that, I would say. What you mentioned, some really specific injuries that some generalist physios like myself wouldn't see very often. Maybe sesamoiditis actually is a helpful one, because I've seen a few of them, and I've got a case at the moment who has had it before and he recovered, and he's now got a bit of a plantar fascia thing. So selfishly, I'd quite like to know a little bit more about those things. Yeah,
the sesamoids, it's funny how someone called me Miss Sesmoid once, because all I talked about was sesamoids on Instagram, because I see so many cases. Like, I think in a day I saw 7 once. That's the most I've ever seen in a day of just one, such a niche, tiny part of the foot. And when I tell people what I do, I was actually working with the principal of one of the shows on something, and he asked me what I'd been doing. I said, I'm writing a talk on sesamoids. He was like, what, the sesamoids? And when I told him what it was, he said, you specialise in that tiny bone of the foot? It's so specific. But it can be such a debilitating injury, and it can become chronic quite easily. And those are the ones that I often see. So I feel really passionate about people identifying it fast and treating it better the first time round, because it's a bone stress injury. You know, it's not just a bit of soft tissue overload. We've got to treat it like all the stuff we've already talked about. So, but it's also, the sesamoids are high risk bones. So they don't have a good blood supply. Depending on the type of bone, so you can get bipartite or tripartite where they don't fuse. I think it's between the ages of 8 and 11 where our bones fuse, and you get things like the posterior process of the talus, which can become an ostrigonum. That all happens when we're sort of 11 years old. So you get these sort of bony morphologies. And if you do get a bipartite sesamoid, sometimes that can mean that it doesn't take the load quite as well. And I think it's to do with the synchondrosis of where the bones connect can become irritated. So you can get bipartite sesamoids, you can get fractured sesamoids. And of course, if you look on imaging, that can look a bit like a bipartite sesamoid, so they can get missed. Bipartite sesamoids, we used to think were in 7 to 30% of the population. Now we know it's probably more like about 50% of the population. They're really much more common than we used to think, because we only used to scan symptomatic people. But if you scan asymptomatic people, they've all got them. I've got a bipartite fibular sesamoid, I happen to know, which is quite rare actually, because I hurt my left foot this summer. So I was like, oh, that's interesting. So you can have a bipartite sesamoid. As I say, fractured. Sesamoiditis is actually just, it's a bony stress response in the sesamoid. So it is a bone stress injury. If that then progresses, that's when it can fracture. And then if that's not picked up fast enough, that can then become a non-union, so it doesn't heal. And then if that's not picked up fast enough, that can then become an avascular necrosis. So when you start to get into the chronic issues, that becomes much harder to treat, because even if you offload somebody, it's not going to heal. Like, what do you do then? So it gets to the point, like with other areas of the body that have avascular necrosis, different from a hip, because the hip's such a huge joint. But I'm thinking of like in the foot, like the second metatarsal you can have Freiberg's, which is like an osteochondritis dissecans, that name. So and that's similar kind of thing. So you've got that bony kind of decay, and actually it's painful while it's happening, but once it's done, the pain goes. Then you get the fallout after then. So you've got like a dead bone, and then everything around it can become inflamed and sore, and then it's hard to get everything to settle down. I had a patient the other day that had an avascular necrosis in the sesamoid, and she asked me what it meant, and I was like, God, how do I say this without saying your bone's dead? I went round the houses. I wrote an email in the end to her. I can't remember if she asked me in person. In the end, I wrote it in an email, and it took me ages to word it correctly, and I can't remember what I said now, so I can't tell you how it was. It was good though. I was like, yeah, that's good. That explains. I think I said there wasn't any activity in the bone. Yes, I think that's what I said. So I said it means basically that the bone didn't have the right blood supply, and now there's less activity in it, which means that when we know that, because when you image it, it's not showing on an x-ray. It looks like it's not as dense. That's it. It's lost its bone density. All of that, anything to say your bone is dead. So that's the spectrum of injuries. And if you don't treat it right at the beginning, then it can progress through those. And then, like I said, you've got a chronic issue, which is harder to manage. So my main message around sesamoiditis is that if, a bit like with the navicular bone stress, one that you don't want to miss, if they have pinpoint pain underneath the metatarsal, they either do exercise in bare feet, or they're a barefoot shoe runner and they run on the forefoot, or they're someone who climbs up, like a trail runner, and they run up hills on the forefoot, or anything that loads the forefoot a lot. They've got pinpoint pain under the ball of the foot, especially if they've got things like night pain. I would be imaging that as quickly as possible to work out, is it the sesamoid? If you don't have imaging, then you treat it as if it is. You just say, right, this could be bony bruising in that particular bone. It's high risk. We're going to offload you now so it doesn't progress. And if you can get that to settle down and then address the risk factors as to why it happened, you can get them back, and they respond really, really well. They become a problem when they're missed, loaded and loaded and loaded, then don't fuse, and then have all these chronic issues. Or they're only offloaded and then put straight back into the sport they're doing without looking at any of the reasons as to why they got it. So there's lots around that. I mean, I work with barefooted athletes a lot. So interestingly, I saw a footballer this week with a sesamoiditis. But the great thing about footballers is that they wear boots and they can have orthoses. Massive help to offload parts of the foot. So they've seen a really, really well-known podiatrist who had given them an insole which would offload the head of the metatarsal and the sesamoids. The boots can be designed to make sure where the studs are. You mustn't have studs underneath the ball of the foot or wherever the excess load is, like in a fifth metatarsal stress. And then we looked at foot strength with them, for example, but they had a really weak, hypermobile big toe. So what they didn't have whenever they pushed off or changed directions was that ability to press down and transfer the weight of the body through the foot. And if you think about it on a hypermobile big toe, so the big toe went way past 90 degrees as I pushed it, no resistance at all, but also not strong when I got it to push. So without that strength, you're going to sit into the sesamoids more, and that's how they get overloaded. So there is research to show toe pressing force. So if you test someone's foot strength, there are dynamometers that test toe curl, toe gripping force. There's also dynamometers that test toe pressing force. So this version of toe strength is far more correlated with someone's ability to change direction than a toe curling force. So if you think about what most sports, no one ever has to curl their toes, actually. Yeah. It's not really a functional.
Press into the ground.
Yeah, you press. So I said to the team with the football, I said, we need to get her toe pressing force better, because no wonder she can't change direction. She's got no force there at all. Like, she's doing it because she can compensate and she's in a boot. But if that had been a dancer with no structure around the foot at all, they'd never have gotten back at any level. So with dancers, they have to be perfect when they go back because they're bare feet. Like you couldn't be harder for them. You can't cheat that. You can't help it with any kind of orthoses or footwear. So I have seen many cases in dancers. Often they will have a hypermobile foot, so they'll sit on the heads of the metatarsal, their toes will flex up, super bendy, no strength through the foot. They'll often have a foot position where they sit into the first metatarsal, more particularly dancers, they do that because it looks nice, and that will overload the medial sesamoid. What other risk factors? A plantar flexed first ray. So if you look at the foot, you can wiggle the first metatarsal, and often in a more cavus foot type, the first ray sits in a more plantar flex position, so that will overload the sesamoids as well. So there's other things, but if you can address some of those issues, so if somebody has a tendency when they rise to roll the foot onto the big toe, if you can correct that, that's going to help. If you can also rehab their foot strength, so they've got loads of forces they push down, they're not going to sit into the head of the metatarsal. What else? If you can get somebody to work through their pronation and use their foot, let their foot deform under load a little bit more, that probably will help a little bit as well. So all of those things on top of offloading them effectively, education around why it's happened, and then rehabbing them bit by bit by bit. And the rehab has to also think about surfaces that you rehab people on. So for forefoot issues, so capsulitis, sesamoiditis, any kind of metatarsalgia, so neuromas, bursitis, I always use really soft surfaces, so barefooted, but never on a hard floor, always on a folded towel. And then that's something that you then start to wean away as they get stronger. So the surface is really important. It's such a sort of, it can be a really detailed niche rehab, but on the chronic cases, it makes all the difference as to whether they get back or not.
You were showing me a very interesting way of assessing big toe flexion strength a few weeks back. I'm sure there's something on your Instagram if people want to have a look at it, using the force frame, which I hadn't seen done before, and it worked really, really well. I've used dynamometers before for that, but as you were describing, it's you get an element of error that you have to accept. But with the force frame, it was a really clever setup to be able to confidently know that you're assessing big toe flexion. So if anyone's interested in looking at that, I think it'd be a useful thing to explore.
Yeah, so at the moment there is still no real gold standard as to how to measure foot strength. When you think about, we've had hand grip strength for how many years? It's much harder to isolate the parts of the foot that you need to isolate. So that's the problem with dynamometers, like handheld dynamometers, because the foot, the big toe or the toe flexors share a neural drive with the plantar flexors of the calf. So as soon as you get somebody to try and use their toes, they will naturally plantar flex their foot. Now, we know the calf can lift twice body weight, often more than that. And yes, the foot has to then transmit that into the dynamometer, but you're getting massive readings that aren't really foot strength. They're coming from the plantar flexors, unless you can isolate the foot in neutral and really isolate that big toe flexion, which is what the force frame setup does, and what a lot of the custom-made dynamometers in the research do. They're just not commercially available. Because if we had them, we'd be away. But they're brilliant, but they're just, you can't get them. So the force frame is the closest thing that you can come to at the moment, which replicates the gold standard foot strength testing. And there was a paper, I believe it was published in 24, but I can't get hold of it. It was published by La Trobe University and the Australian Ballet team, where they set up and measured very carefully to see if it was reliable and repeatable. And they used the force frame as I did with you. So tilting the paddles up so the toe is in extension, pressing down, foot in neutral, hip and knee at 90. They also added like a strap across the knee to really keep the heel down. And then they added in fifth toe flexion using the valved dynamo, but they did it as a pulling force from the top. So that paper actually shows what is the closest thing we've got to gold strength foot strength testing at the moment, but I can't get my hands on it. I don't know if it hasn't been published yet. So I'm sure that my setup could be better, but I need to see that paper actually. But for now, it's pretty good. If you have a force frame, it's easy to replicate.
And how important, if we're talking about measurements here, how important is calf strength?
So it's really important. It's one of the things that I look at all the time. I mean, obviously, unless I've got access to the force frame or the force decks, when you can set it up with the bar across and then look at isometric seated calf raise strength. I do a single leg calf raise test in clinic, which is, just how many reps to technical failure. And all the research always comes back at around 24, 25 is the number you want. There was a new paper published like last year, same number, about 24, 25. So if you're looking at more endurance, that's a very useful test. You have to make sure that you make sure they don't make compensations or errors. But if you're looking at true isometric calf strength, it's the seated position that you want, which people say tests soleus, but it doesn't. I mean, they looked at, there was a paper by Kim Herbert-Lossier, but I think it was, I forget the date on it now, it was a while ago now, where they looked at how much the soleus activated in comparison to the gastroc with different levels of knee flexion. And at 45 degrees of knee flexion, there was only about a 4% difference or something between them, which clinically doesn't make any difference at all. Now, that wasn't 90 degrees. But the reason to test people in dorsiflexion is because, a bit like with the toes and extension on the foot, that's where we produce our force. That's functionally where we can get the most amount of force out of the calf. So that's why you want that 90 degrees at the hip, 90 degrees at the ankle. And the ankle should be, some people say to test it in full dorsiflexion, because that's where you get your most force. But if you have any ankle restrictions that mean the person can't get into full dorsiflexion, it then means it affects your symmetry side to side. Mm-hmm. So say they've had an ankle sprain and they've got limited dorsiflexion, which is exactly the kind of person you would want to test this on. If you're looking at contralateral side as a comparison potentially, then it makes it an unfair test because you've got limited dorsiflexion. So there's some people that say just test it in neutral, but not more than that. It should be at least a neutral. And if you look at Seth O'Neill's work, there was also a paper published by Sancho, I think it was 2022. You're looking at around 1.5 to 2 times body weight to be produced in that particular condition setup. So for more elite athletes, I'd be thinking at least 2 times body weight. Some people say more, 2.2 times body weight is sometimes desirable. But then if you think about when you're rehabbing somebody and you think how easily the calf, not easily, but a calf can lift that amount of weight, you have to consider that in the rehab. And there was a paper in 2023 published by Osborne who did a systematic review of all the foot and ankle strengthening to date, I think, or like within the last 10, 15 years. And they basically showed that none of it ticked the boxes in terms of ACSM guidelines to exercise prescription. It was all underloaded. I say none, it's probably too black and white. Most of it,
I can believe it.
Yeah, was underloaded. And most of that research was actually calf research because there's not much on the foot. So that means that most of our research today is massively underloading the calf. And we know the calf is, I mean, we're great at loading like quads and glutes and hamstrings. The calf is better than the foot, but you can load the foot with 2 times body weight. I've done that with rugby players. So I had somebody come back from a turf toe injury, and it was the second opinion one where they couldn't get back to scrum. So they would go to push off and just, it would be too painful, or it was more too weak, I think, and they couldn't hold it. And I was like, well, what's his toe pressing force? So they'd test it, I think, with a dynamo pulling up against almost like a brake test. When I did it on the force frame and we compared side and side, it was about less than half of what the other side could produce. And I was like, there's your problem. His toe's not strong enough. Yeah. So we showed him all of the foot exercises. Again, this is crediting Romain Tourlon with this because this is where I got it from. I know lots of people who work with the foot and ankle use his work because there's not much of it around, which really looks at heavy sporting load for the foot and the ankle, but his is fantastic. But he talks about the toe pressing exercise where you, on a wedge or an incline board or a rolled up towel, but if it's heavy loads, obviously a wedge is better. Raise the toes to 30 degrees, get a barbell on your back with 100% of your body weight, so you've got double body weight, but don't do a calf raise. So you lift the bar up, and then what you do is you lean forward into the squat rack. So your force it's down from the weight, but it's also horizontal. And whenever I try it, this is what I teach to people. You can bias the calf or the foot depending on where the load is. So I always make sure that people have done it with me if they're going to go home and do it. And I say to them, now rise up. Can you feel it in the calf? Yeah. Okay, now come down, lean forward, press into the toes onto the board, and you feel it in the foot. That's how you load the foot. And if you think about sprinting or change of direction, that's the exact position you're in. That's why that correlates with change of direction work. Yeah. So, but that generally that is not happening even in elite sports teams now, because I see them as second opinion and that the rehab hasn't quite ticked that box. So it's only going to be a year or two, everyone will do it because it's coming in now, and I'm teaching people to do it all the time, and I see it all the time now. So it's even more than 2-3 years ago, people are much better at foot rehab now, I think, than they were. But those are the things that make just that little bit of difference. And even though he'd been doing heavy calf work, and people say, but if you do calf raises, it'll bias the foot. But it didn't. Yeah. It didn't. I can show you his tests.
Wasn't driving through the big toe.
That's it, because it was painful, or he was fear avoidant, or he'd compensated. People are so good at compensating.
Especially athletes.
Yes, and dancers are amazing at compensating. So, sometimes there's criticism around stop making your exercises so specific and stop being so fancy and finding problems on it. But his foot strength wasn't strong. He could squat double his body weight, but his big toe was weak.
I just think on average you don't need to be super specific, but those people that are coming in for second opinions is because the average hasn't worked.
Yeah.
You have to then solve the problem. You have to then think outside the box. And by the sounds of it, actually for you, it isn't really outside the box, it's the box, but people don't know about it. So
I'll be out of a job. Like, I really think like in 2 to 5 years from now, I think everyone will be really good at the foot, because that stuff's coming out now, and I talk about it, other people talk about it, it's all over Instagram. So I don't, so far this year, I found a few cases where that is the thing that's been missed because people don't know about it, but they're learning now. I see it all the time. So I'll have to find other things to correct.
I tend to find that calf raise height, the single leg calf raise height compared to double leg, is a quick indicator for me of whether their calf is not just has endurance, but has strength, has power. And I will then have a look at other things as well. Force plates will sometimes get used, but it's such a quick and easy thing. Just measure it from the floor. And one is often very obviously different to the other, because they've been doing loads of endurance work, but they haven't worked on genuinely driving through to in a range of calf contraction. Yeah. So then they have to sometimes offload body weight, and which therefore tells me they haven't got at least 1 time body weight calf strength, when you're saying they need 1.5 to 2, maybe 2.2. So there's an obvious place to start for most people. How high can they raise off the floor? And a lot of people, depending on the injury, but even people who haven't necessarily had a severe injury, they still can't even get full height on the body on a calf raise.
The other one, which I learnt this from Seth O'Neill, is looking at their neuromuscular control. So, when you see somebody do a calf raise and on the way down they shudder. Yes. That shake. So, have you heard about this?
No, but I haven't heard about it, but I've watched it, and I talk about it to my patients, because you just see it. It's not just happening in the calf, it happens all over the body. So it's like, that's interesting to me. You don't have good eccentric control through a calf raise. We need to work on that.
Yeah, and what it actually is where the muscle fibers are sliding over each other, rather than it being a coordinated, slow descent, it literally stops and starts. Yeah. So that's what gives you that shaking effect. But what I thought was interesting is that in the calf, that almost becomes baby stretch shortening cycles. So it's loading the tendon heavier. So if that's a deficit, that could make tendinopathy worse. So when you rehab it, you can do things, any kind of rehab will address neuromuscular control, but there's a few exercises that Seth talks about, and I now teach it as a tiny part of when I do the calf on my courses, I just add it in because I think it's a nice addition. And most people haven't really heard about this. But it's totally Seth O'Neill where I got it from. It's not me, but he gets people to to play with the height. So he says to them, okay, go up by 50%, now drop by 1 centimetre, now go up by 1 centimetre, now go all the way down, then go all the way up, then come down by 1/3. So it gets them to control it up and down. So you can do some control work before you then load them heavy. And then the loading heavy into eccentric range presumably then also helps address it. But then he also talked about how we still don't know why calf loading helps tendinopathy. We sort of do, but we don't know for sure. And one of the reasons is we think it's to do with that improvement in that neuromuscular control, and that the collagen, but the way that the tendon slides over itself, that's part of the reason that tendinopathy becomes better. So it's the control, and it's not just the strength, it's the control of it as well.
What about the plantar fascia? Why do you think the loading helps on the plantar fascia?
God, I think it's to do with foot strength. So again, plantar fascia is a passive structure in the foot, and we used to think it was to do with the tensioning. That's why we think the stretching helped and things. I think that's probably more likely to be neural. So you're kind of giving it giving a novel stimulus to the brain, and also stretches are isometric exercises. So especially to people who aren't active, that's a load. So probably that's some of the mechanism, but the intrinsic muscles go into the plantar fascia, but they all do the same thing. So with the windlass mechanism, as I told you, so the intrinsic job is to help the plantar fascia stiffen the foot. So if you can bulk up the muscles, it's going to offload the plantar fascia. So, and like I said, with that that study by Ratliff, which was like 11 years ago now, I think we used to think it was the tension through the plantar fascia, but now we think it's probably because actually it was targeting foot strength. I deliberately didn't say intrinsics then because it isn't just the intrinsics. So there was a bit of a trend like a few years ago of calling it foot core, and talking about intrinsics, but it's not intrinsics. You can't isolate the intrinsics in the same way as you can't isolate your deep transverse abdominis. So when I teach it, I say we're not going to talk about intrinsics, we're going to talk about foot strength. Because if you're doing, I don't know, if you're doing that toe press exercise I told you about, tib post and perineals are working like crazy to control the ankle. Any kind of balance.
So this is what I believe about bent knee calf raise. I heard bent knee calf raise being dismissed about, we don't need to do it because gastroc work just as well in a straight knee.
Yeah.
But I know that when you do a bent knee, the perineals and the tib post, they are working so much harder in that position. There's so much more stability going on that I still give it out all the time because I think it's a highly valuable exercise. I no longer believe that it's about the soleus being biased necessarily. That's, as you said earlier, that's not necessarily it. But I will still separate the two exercises because I think there is a difference.
Yes, and Seth O'Neill, I think, would go further and say that, and Maliaris would say this too. It's in he did a blog this year where he sort of presented a new framework for rehabbing tendinopathy, and he talks about difficult and dangerous positions. So your end stage rehab has to involve, like, what position do you push off in? You're not on a straight leg, are you? Yeah. So, or where do tendon ruptures happen? It's when your foot is in dorsiflexion pushing off behind you, or that's basically the examples, difficult, dangerous positions, and then Seth talks about how if you think about the fibers of the tendon as they're cylindrical before they insert into the calcaneus, so you have this kind of uneven tensile strain. So you have to strain all those fibers in different ways in order to rehab the full tendon. So you have to pronate and supinate the foot. You have to bend and stretch the knee. You have to drop down into dorsiflexion to get all those fibers to work. Because if you don't, you're going to miss the bit that's weak because people compensate. Mm-hmm. So if you think like if people have to turn and push off, they're in probably mostly dorsiflexion. The foot's going to be going into pronation, but then into eversion. The toes are in extension, and that's a massive pushing force in that particular position. So very different from even a straight bent knee calf raise. So when I teach my course, I talk about how to get variety into Achilles tendon rehab, and we do about 6 different exercises, and every single one targets it differently. One is slow, one is fast, one has foot eversion because that'll get medial gastroc. One has top plantar flexion stiffness. One has, we do like heavy isometrics. So they're not yielding, they're overcoming. So Maliaris talks about yielding isometrics where you just sort of resist the load that's against you, or overcoming isometrics where you push through them really heavy. And he said, because Maliaris argues there's space for isometric rehab in end stage rehab, but it has to be overcoming and sport specific. So get the person on a bent knee, tilt the foot, push them into a wall for 5 seconds, hard, heavy push, as hard as you can, overcoming isometrics. That's a great end stage exercise, but it's isometric.
But that's used in S&C. Strength and conditioning, performance-based work is used, and that is beyond end stage. That is performance, right? That's the performance world. So that's what you need to be doing in end stage rehab, is replicating what they're about to do in their performance. So absolutely makes complete sense to me. Look, we're coming towards the end of the episode here, and it's been, I can tell there's more that we could have spoken about. What else have we missed that might be important just to finish the episode on? Have you got any nuggets, anything, any bit of gold that can just tie a little bow on the episode for us?
Yes. I'm still thinking, what can we talk about? We talked a little bit about ankle sprains, but one of the big fallouts from ankle sprains is chronic ankle instability. So it's just to reiterate what we said right at the beginning, which is rehab ankle sprains well. Like now, if you look at ACLs, there is so much research. All the research that I used to use for the foot and the ankle came from the ACL section because there was nothing on the foot. There's starting to be more now. But we do so much to ensure that an ACL is well rehabbed and fit to get ready for sport, partly because we've got the research to support that, actually. But we don't do enough for the foot and the ankle. There was a paper that came out last year before, which is by Pico and his team. They've done a lot of research on end-stage testing for ankles. It's called the Ankle Go. That's a really good paper if anyone wants to look at some 4 different testing 4 different tests and then 2 different patient reported outcome measures, and then like a total score gives you a bit of an idea of how the patient is doing. But just to say, just rehab ankles better, because they have so much fallout. Chronic ankle instability is really prevalent, and then impingement is also really prevalent. To a quarter of the people that have ankle sprains will get some kind of impingement, but the one that is related to chronic ankle instability more is the posterior impingements. It might be a little bit less common. I don't know. It's very common in what I see because it's one of the most common injuries for dancers, but other sporting populations can get it. But yeah, just to say, if you get a posterior ankle impingement, it's not about the plantar flexion. It's about the change of direction, work, and the instability in the joint. That's what's giving them posterior ankle impingement. It's not just because they have to keep pointing their foot. So a footballer who's kicking or a cricket fast bowler who's landing with their foot going forward, look at the stability in the ankle, because that's often the driver.
In difficult and dangerous positions. Is that what you...
Yes.
Yeah.
That's not me. That's Maliaris, I think, that said that. Yeah. Exactly that.
And it's actually quite a personal end to that episode, because I had surgery for chronic ankle instability at the end of last year, and I did my first injury before I was a physio, before I knew any better. I then did the same injury on my left side, rehabbed it as well as I could possibly do. I sought a lot of help from other physios to get guidance. Never had a problem with that one since. That was 5 years ago. No problems with my left side. My right side that I didn't rehab so well when I was 16, 17 years old, I think I had 5 sprains within 18 months, followed by mildish instability, followed by severe instability after another re-injury a year and a half, 2 years ago. And yeah, luckily I'm at the other side. Surgery went very well, but that's not always the outcome. So I completely echo that. I say it a lot, is that manage it well at the start, protect it properly, rehab it fully to the end, because chronic ankle instability is no joke. It's no fun. So.
And really prevalent.
Yeah. Because too many people call it just an ankle sprain. So there we go. Well, thanks so much, Liz, for coming on. If someone does want to hear about you, you've spoken about your course already. I'm sure there'll be many people wanting to come on the course. How does someone find out a bit more about you?
Just search. I used to be on Twitter more, but it's not any good anymore, is it? X. So I've sort of not really on X, but Instagram's probably where I'm most active now. So it's Liz_Bayley_physio, or just if you just Google me, I've got a website as well. And I'm going to I did one of my courses recently. There's another one early next year, but I'll definitely do 2 more next year. They're not set yet. And they'll be sort of new and improved. I'm going to bring in a bit more objective testing into those, because one of my personal goals this year was to use more objective testing, which is why I was talking to you about the force frame. So I'm now bringing that into my course, because I kind of have to. Otherwise, you're sort of behind the times now. I think if I know not everyone has access to it, but a lot of the people that come to my courses do have access to it. So I'll be adding that, plus looking at data with my new... I've just gotten involved in the output sports system, which is a little accelerometer and an app that goes with that. So I'll bring all of that into my course. I don't know how, because it's already got too much in it, but it'll be there somewhere. So it should be good. It'll be new and improved, hopefully. But yes, just you can Google me to find my website that way.
So we always ask our guests something quite personal to me. So my why in the world, and my business why as well, is better never ends. It's a very important way that I live my life. It's part of my value system. What does better never ends mean to you?
So I suppose for me, I think there's a lot of talk about with physiotherapy how you can just do the basics really well, and how important that is. And there's no question that's one of the most important things, especially when you're newer to the profession. I think once you start to become more experienced and you see the more complex cases, it's very true that like the more you learn, the more you realise you don't know. And that's something that haunts me a little bit. And actually trying to overcome that and remember what I do know as well. Because sometimes I think I'm just going to stop, because I don't know everything. I still get threatened when I see a case and I think, oh my God, I don't know what that is. And it makes me want to quit, because I think I've been working so hard all these years and I still don't feel confident with every single patient who I see. But then there's some patients that I feel really confident with, but that's definitely part of the job. It's part of medicine, the uncertainty. And I'm trying to embrace that. So I suppose for me, I've always been the kind of person to really strive to be better and improve on things. And I think one of the best ways you can do that is to shadow people. That's when I've learnt the most, I think. So if we can continue to share our thoughts, you know, doing podcasts like this, but also accept that actually physio is a really hard job. I talk about this with some of my closest physio friends, and we have little breakdowns now and again. And I thought when I started it was hard, and I thought, oh, by the time I've been doing it 15 years, I'll be good. And I'm not yet. You know, I have good days and bad days, but actually just accepting that that is part of it. But also if you have bad days, that's what gives you the motivation to get better, I suppose. But just accepting it's hard. I think if you're in this kind of a job and you struggle in any way, shape or form, whether it's with the time management, God, we even talked about time management is like the bane of my life. You know, the shouldering people's woes and sadnesses and worries and taking that home and the constant interaction through the day and how exhausting that is, then I think that's a very normal and necessary part of the job. But just to keep doing it because it's so valuable.
Thank you. That's really powerful. And I don't normally offer an addendum, but it's really made me think about my processes and what I do there. And these days, I have to, and I know that this is a more recent realization, probably the last few years. I am much happier to say to my patients, I don't know what this is, but I know how I'm going to find out. And I'm much happier to say that now because I embrace that uncertainty. And you can't do that until you've done the hours of the basics, as you said, of exploring complex cases, of dealing with hard stuff. You can't say, I don't know, as easily until you've gone through that process. It did actually, that was quite a personal reflection there, that it's only recently that I've been able to confidently not know. Yeah, because up until now, I've hated that feeling. Hated that feeling of panic that's building up.
Yes.
I don't know what to do here.
Yes.
I really don't know what this is. And luckily we share some people within our network, and we'll mention his name again, Dr. James Noak. He's an unbelievable problem solver. And he was on our podcast very early on in our journey. And people like him I can lean on and say, I've got this case I just can't figure out. And he'll normally have something to consider. So I just felt like I had to there. So thanks for sharing your version there. And it comes, doesn't it? Mm-hmm. It comes with time.
It's good to know that you still feel like that too, because you do think, when's it going to end? When am I going to be confident? And you will be some days and you won't be some days. So
and I think that the key is that I'm now confident
to be unconfident. Yes.
Yeah. Well, thank you so much, and it's been a great episode.
Thank you for having me. Pleasure.
Thanks for listening to today's podcast. This podcast is sponsored by Better, provider of health and wellness services in central London. We really believe that we can help people feel better and live better. You can book in for face-to-face services at any of our 3 London clinics. We have one in Marylebone, one in Soho, and one in the city. You can also follow us on Instagram at Better Never Ends, or head over to our website for more information about the clinics or the podcast at www.betterneverends.com.